All right, welcome everyone. So I'm very excited to be talking to you about simple psychopharmacology. I'm going to give you quick tips today as kind of a primer and a foundation for psychopharmacology in your practice. And I am more than happy to teach something longer and go into more detail on the psychotropics. I'm also more than happy to be available to people for individual consults. So feel free to email me. In case you don't know, I'm the president of OPA right now. So I've been active on the listserv, but I'm happy to give anybody my contact information to reach out to me. If you have specific questions about particular clients or anything like that, I'm happy to help out or offer direction. Real quick, you guys had an opportunity to read my bio on the actual continuing education event, but I received my doctorate in psychology from George Fox University. Did most of my foundational training at the Department of Veterans Affairs, where I did actually interact with psychiatrists and really get to know medications in a more advanced format. I pursued my postdoctoral master's in clinical psychopharmacology from the Fairleigh Dickinson University. It's an APA designated program. APA only accredits PhDs. They don't accredit master's programs, so they do a process they call designation. So I received that. I have had the opportunity to work under the supervision and direction of Dr. Jim Phelps, who's a national expert on bipolar disorder, as well as collaborate with Eric Schmidt and a few other clinical pharmacists who are board certified in psychopharmacology. So I've had a lot of wonderful opportunities to really gain enhanced knowledge and interact with this in more detail and have put together a team that's really effective and helpful at talking about psychopharmacology. So today, the goal of this particular presentation is to really help you guys understand the terminology and really understand the three monoamines. The monoamine hypothesis is really what dominates the pharmacological world as it comes to treating mental health related concerns. And when you have better understanding of the monoamines and you understand what we call mechanism of action, you actually have quite a bit of solid foundation to help your patients understand what's happening to them, what medications to talk to their doctors about, avoid, and really be in a positive consultation capacity. So my goal is, I'm very big on simple. I understand that simple does not encompass all of the complexity of the world, but I'm really big on providing this information in an educational way that you can share directly with patients. You will receive my PowerPoint at the end of this in an email from info@OPA. And so you will have some of these slides to actually use as examples in your office if you would like to, because I use some of these as direct examples. So my goal is to help you understand the monoamines, understand and convey side effects and what to expect from a medication, and understand concepts like mechanism of action and metabolism, because this will actually help you understand what is a good avenue for your patients to pursue. And all of this will be pretty well understood at the end of this hour. A really quick note I wanted to make about the Oregon Board of Psychology. So the APA has practice guidelines regarding psychologists' involvement in prescriptive and pharmacological issues. They have three tiers. The first tier is psychologist as prescriber, which is for the Department of Defense. They've been doing this for well over 20 years. New Mexico, Illinois, Iowa, Louisiana, and the Indian Health Service. So psychologists are able to actually get a prescriptive authority within those systems. It requires a postdoctoral master's and a prefectureship or supervised hours. So it's very similar actually to a nurse practitioner. And for example, in Iowa, it's similar to a physician's assistant model where psychologists actually operate under the supervision of a medical doctor. Tier 2 is psychologist as active collaborator with prescriber and patient. Traditionally, we're taught in our postdoctoral master's programs that this is where we are able to fall when we have this postdoctoral master's, because we have advanced knowledge and understanding of the anatomy, the pharmacology, and the specific medications and their interactions. And then tier 3, which is the most common, is psychologist as information source with the patient. And you'll see a descriptive paragraph below tier 3, which describes tier 3. And so this is where we are safely and comfortably resting today. And this is, the Oregon Board of Psychologist Examiners has not necessarily adopted the APA guidelines. They're not required to. They're offered as guidelines for clinical practice. But this is where our board tends to be most comfortable. is in the idea of tier 3 is psychologist as information source with the patient, where you're really helping them understand what to expect, why their side effects are happening, and relaying them back to their prescribing provider, or perhaps saying, hey, next time you meet with your prescriber, I want you to ask them about the potential of getting off this medication, and maybe trying an alternative like, this or that, and talk to your prescriber because I think that might be a good avenue for you. So you're serving as an information source, but you're not giving direct, like, discontinue Zoloft, initiate Prozac at X amount, if that helps people understand. So real quick, we're going to go over a couple of terms. We all learned these things in graduate school and we've been exposed to them, but I always like to do a very brief reminder, and I think it can help. So when we talk about an agonist, we're talking about something that is for, promote. So a dopamine agonist increases dopamine's activity. A dopamine antagonist reduces it. So an agonist is for, an antagonist is against. Again, we're going to talk about synaptic transmission. So when we talk about mechanism of action for medications, we talk about selective serotonin reuptake inhibitors. We talk about serotonin modulators, anticonvulsant mood stabilizers. We use all these fancy terms, and really what they relate to is anticonvulsants affect transmission down the axon, so they slow conduction, which is why we often use them for bipolar or pain, because they slow, therefore reduce the severity of certain things. A reuptake inhibition stops, it happens at the axon terminus, so it prevents the axon from reabsorbing the chemical. So that really helps increase bioavailability. And then when we look at modulation, we're looking at more efficacious, we're looking at more effective use. So consider anticonvulsants are like speed limits on a freeway. Reuptake inhibition is adding more chairs to a game of musical chairs so nobody falls. And modulation is efficient use, right? It's more effective and more efficient use of a resource. So today we're going to talk about the 3 catecholamines, otherwise known as the monoamines: serotonin, dopamine, and norepinephrine. I'm also going to cover glutamate, GABA, and voltage-sensitive sodium channels a little bit, because these are highly relevant. The monoamine hypothesis is the prevailing theory by which we manage psychological conditions. And that is the idea that the vast majority of psychological issues arise from chemical changes in serotonin, dopamine, and norepinephrine. That's why when you look at the vast majority of our medications that we use to treat psychological issues, they interact with serotonin, dopamine, or norepinephrine. Some of them increase it, like Wellbutrin increases dopamine, atypical antipsychotics reduce dopamine. But for the most part, if you've ever seen the little, like if you've ever tried to change contrast, color, or saturation on a photo, what we're constantly doing is we're trying to change color, contrast, and saturation of these 3 chemicals in order to make the effect that we want. Additionally, glutamate and GABA have a huge impact on overall psychological functioning, and voltage-sensitive sodium channels are probably the other dominant kind of clinical implication. That's where you find mood stabilizers, Depakote, Lamictal, Trileptal, Tegretol, all of those tend to work in this particular. So those are the anticonvulsants. We'll cover those briefly. Before I proceed, are there any questions? Are people feeling pretty okay with the pace and kind of what we're covering? You can give me a thumbs up if you want. Thumbs up is an option. All right, well, with no complaints, I will proceed. Please feel free, like I said, to interrupt and ask me questions as often as you like. So, serotonin. Does anybody know where the majority of serotonin is found in the human body? 90% of serotonin in the human body is found here. Well done. Excellent. Yay. I love it when people understand this, because yes, the digestive system is where the vast majority of serotonin actually lives. And serotonin is the most complex of the monoamines. It actually innervates more body systems, so it probably has one of the largest impacts on the human body. But when we think about nausea and diarrhea and some of the effects that we have, kind of the principal side effects of antidepressants, you start to understand, well, of course, if 90% of serotonin is in the gut, then your principal side effect of increasing serotonin is going to be gut related. So it helps us understand that. Also, if any of you are familiar with polyvagal theory, and you look at the vagus nerve as it innervates the digestive tract and how that's related to trauma, post-traumatic stress disorder, and other body systems, we start to understand how serotonin has a crucial impact in kind of psychological functioning. So when we think of serotonin, the acronym that we want to remember is DOMAIN. So domain is how we understand the effects of serotonin on the body. So serotonin is involved in depression, the regulation of mood. But what's interesting is the effect size for serotonin in treating obsession is greater than that of treating depression. So believe it or not, serotonin is actually slightly more effective at treating obsessive compulsive disorders than it is at depression. Excuse me. But that's actually because 5-HT, which is the serotonin, it aids with the satisfaction sensation. So this is very interesting because many of you may know, and we'll talk about this a little bit in more detail, but many of you may know that people who take antidepressants tend to have actually a loss of sex drive. They tend to have diminished sex drive, anorgasmia, the inability to achieve orgasm. And one of the theories behind this is all of their systems are already satisfied. They just don't want or need it because they're okay. So it's really effective with obsession, which can be very helpful too, because a lot of antidepressants treat compulsive eating and some of those anxious ruminations that we engage in. Migraines, so 5-HT can actually abort a migraine once it's started, which is why a lot of migraine medication interacts with serotonin. And interestingly enough, if any of you are familiar with the pain medication tramadol, tramadol actually has a serotonin reuptake component. So the more tramadol you take, the more serotonin involvement you get, which is one of the theories why it's an effective pain medication. And also one of the reasons it's less deadly because it's less likely to suppress respiration and more likely to cause serotonin syndrome if you keep taking more. It drives gut motility. It helps with anxiety management and nausea. So blockage of serotonin tends to prevent nausea. So people who take Zofran, for instance, are blocking serotonin, but this is interesting. Perfenazine, which is another, it's an antipsychotic that we often use for especially pregnancy related. Sometimes in the presence of trying to treat nausea, we can actually induce a little bit of depression because we are suppressing serotonin. Also, fun fact, serotonin is synthesized from tryptophan, L-tryptophan to 5-HTP to serotonin. That's why 5-HTP is actually a common over-the-counter antidepressant mood supplement, and it can actually increase a little bit of the serotonin in the system. But technically, if you have a tryptophan deficiency, you can actually have depression. And naturopaths actually look at tryptophan deficiencies. So, one of the ongoing jokes is there's a reason that, Thanksgiving can actually make people feel better after they feel worse from eating too much because they're actually replenishing some of their body's tryptophan. So if we increase serotonin, we tend to decrease depression, decrease obsession and compulsion, and we decrease that rumination component. This is why SSRIs are actually helpful at onset insomnia. We tend to find that people who take antidepressants tend to sleep a little bit better because they're not doing that repetitive rumination at night. Decrease migraines, decrease anxiety, increase gut motility. So recognize, and Zoloft is a huge culprit for it, even though it's one of my favorite meds. Zoloft is probably one of the more difficult, make the choo-choo train go faster. So it tends to actually lead to diarrhea. Sometimes we can increase gut motility to the point where it actually gets stuck, which causes constipation, but more often than not, serotonergic agents increase diarrhea, which is why they're also used for the treatment of irritable bowel syndrome with constipation. We will increase nausea, which a lot of you have noticed in your patients or yourselves if you've taken an SSRI or an SNRI or something that's serotonergic. That nausea is kind of the number one side effect that people notice right off the bat. The other thing to be aware of is we have commonly heard that antidepressants can lead to suicidal thoughts. And it's more common in adolescence. And one of the prevailing theories is that they don't induce suicidal thoughts. It's very rare that a medication can give you something that isn't there. What they tend to do is make your thoughts more vivid. In the very beginning days of taking an antidepressant that includes serotonin, your brain is going through an actual neuroplasticity process. Prozac is infamous for actually changing neuroplasticity. Prozac has been demonstrated to improve people's fine motor movement after stroke because it actually reorganizes the brain. So I often tell people it's like if you hired someone to come in and clean out your closet, they're going to make a mess before they get better. And so oftentimes when we start a serotonergic agent, thoughts that people have been having are more vivid, including dreams, because serotonin can intensify dreams because it has an impact on our REM sleep. It makes it more vivid, and it can actually intensify nightmares if we're already having them. It can also worsen restless leg and some kind of movements. So serotonin doesn't give you suicidal thoughts. If you're already having them, it makes them more vivid and more clear for the first few days that you're taking it, which is one of the things that I often warn patients about. Like, hey, just so you know, it's not giving you thoughts, but you may notice in the first few days, whatever you're thinking about feels more clear and more vivid. And don't worry, that'll pass, but pay attention to it because I don't want you to follow through with something just because you're thinking more vividly. Dream intensification with SSRIs. So similar response with alcohol withdrawal. Alcohol withdrawal is more the disinhibition. It's the inability of glutamate, the inability of the body to suppress glutamate. However, during the REM sleep cycle, yes, it's kind of the same timing. So different chemical, but same timing, so very similar. So Peter Powers asked everybody in the chat, is dream intensification with SSRIs related to a similar response during alcohol withdrawal? So it's during the same timing, but the alcohol withdrawal component is disinhibition. It's a failure to inhibit neurological processes, whereas serotonin is interfering, and we're not really sure how, but it interferes and makes REM more vivid, but the end result is very similar. So too much serotonin, and forgive me for the language, but when you work in this field, you guys, unfortunately, a lot of medical like a lot of medical acronyms are just, they use offensive language. But so too much serotonin, you get serotonin syndrome, which is called by the medical community affectionately shits and shivers. So diarrhea, shivers, hyperreflexia, and myoclonus. So if you've actually seen people are kind of like jumpy, reactive, twitchy, having a hard time controlling their movements. If you've ever seen serotonin syndrome, I've only seen it twice in my clinical career, but it's a miserable thing. They get a fever. It's interesting because they act like very similar to hypothermia, only they're hyperthermic. Their temperature is high. Their vital signs go all over the place, blood pressure, you name it. Encephalopathy, which is they often you get paraphasia. They make no sense. Restlessness and sweating. So you kind of see this autonomic dysfunction. Like it's like, you know, the whole system has gone out of whack and everything's kind of flipping switches. So serotonin syndrome is very serious. It's incredibly serious and very fearful to the medical community, but far more rare than we would like to make than it actually is talked about. So a lot of doctors are like, oh, I can't increase your antidepressant because it could cause serotonin syndrome. And it takes quite a bit of work to induce serotonin syndrome, but it is a real problem. So if you have patients with bipolarity, the general theme in the medical community is just say no to serotonin. It induces what we call a mixed state. So serotonin reuptake in a person who is bipolar without anything else to stabilize it, and that's more advanced pharmacology, but we can sometimes stabilize SSRIs by binding them with an atypical antipsychotic. But with serotonin reuptake, you will actually often increase or induce mania in a form of agitation. And so they'll be co-manic and depressed, which is why we call it a mixed state. So they're going to still be depressed and a little manic and kind of off and feeling really miserable. Oh, so someone wanted to go back to the previous slide. So I'm just going to send to the previous slide for Alyssa. And just to remind everyone, you're going to get all of these slides emailed to you in a PDF that you can pull up, print out, whatever you want to do with. So don't worry if you miss anything. I promise you, you will be provided with it in PDF form. But so serotonin, when it comes to people with bipolar, we just want to avoid. And often, unfortunately, what we'll do is we will, sadly, a person will go to their doctor and say, I'm really depressed. They'll give them Zoloft, they'll go home and they'll end up in the hospital, or they'll spend all of their money, or they'll do something really sad because we didn't appropriately screen for bipolar. So it's generally an excellent plan to just say, nope, we're going to avoid serotonin when it comes to bipolarity, and we will work with other classes and other forms of medication to try and treat depression and mania that avoid serotonin. So an attempt to overdose an SSRI can lead to serotonin syndrome. That's actually probably one of the more common reasons. So we have had people who have, like if you overdose on something that has no serotonin, like Wellbutrin, it can lead to seizures. But absolutely, overdosing on SSRIs can lead to serotonin syndrome. There are certain medications, we'll talk about this in a little bit. So it depends on the SSRI you're taking. Lexapro is a beast when it comes to serotonin syndrome. Lexapro can be combined with other medications and cause serotonin syndrome at low doses. Prozac, as you take, the longer you take it, it inhibits its own metabolism, so it stays in your system longer. So you absolutely can overdose and cause serotonin syndrome. In fact, it's probably your number one indicator of overdose. But more often than not, serotonin syndrome, if you look at the clinical incidence rates in the medical community, it's because of polypharmacy. It's because of more than one serotonergic agent. It's well-intentioned doctors who start you on Zoloft, and they add Cymbalta because they heard it's effective for pain, then they add Tramadol, and then they add Trazodone, and they keep trying to treat you by adding more, and eventually it just accumulates in the body, like you were saying. Absolutely. So our next monoamine is dopamine. Where is the vast majority of dopamine found in the body? Oh, and yes, Alyssa Murray said to everybody, St. John's wort. St. John's wort is a naturally occurring herbal supplement that does reuptake serotonin. But what do you guys think? Vast majority of dopamine found in the body. So vast majority of dopamine is in the central nervous system. It's actually housed predominantly in the brain. Can anybody guess where the second largest concentration of dopamine is in the body? Oh, yes, Alyssa, you're absolutely right. Yes. So even 5-HT, like the actual supplement 5-HTP and St. John's wort, when you combine them with SSRIs, you can create critical serotonin reuptake. So yes, that can absolutely increase your risk of SSRI or of serotonin syndrome. So dopamine is predominantly found, about 90% is found in the brain. The rest is found in the heart, in the cardiovascular system. So dopamine, we just used the name dopamine. We got a little less creative with this one, but so dopamine is critically involved in drugs. It is the principal chemical in addiction. Reward and want are found in dopamine. That's why stimulants, cocaine, methamphetamine, all of those are extreme dopamine reuptake inhibitors, right? So it's also found in psychosis, which is why you see this. It's why our principal method of treating psychosis is to suppress dopamine, but and also it's why Seroquel and some of the atypical antipsychotics are used by meth users in the community to come down from meth and return to work. If any of you have patients who have been having a hard time getting Seroquel at smaller doses, most insurance companies have now banned the 25 and 50 milligram tablets because they were being used illicitly to come down from methamphetamine. So it's also why a lot of people are struggling more to anecdotally treat anxiety and sleep with Seroquel because the smaller doses are no longer available to the general public. But so dopamine is in reward and want. Increased dopamine reuptake does lead to audio and visual hallucinations. And then reduced reuptake will lead to Parkinsonism or extrapyramidal symptoms. So EPS are your myoclonic jerks and your struggling movements like you see. And it's interesting because if anyone's familiar with the treatment of Parkinson's, we treat it with levodopa-cardopa, which is kind of the precursor to dopamine. We can't add dopamine across the blood-brain barrier. We just can't get it in there. But we can give all the building blocks and hope it gets assembled on the other side. And so oftentimes in the treatment of Parkinson's, because we've so significantly increased dopamine, we can induce hallucinations. So prolactin inhibition, so dopamine inhibits prolactin. So when we block it, it can cause lactation, which is one of the critical issues associated with atypical antipsychotics, risperidone being the largest culprit of gynecomastia, male breast formation. And that's, so you'll see oftentimes people who take atypical antipsychotics, not only is their weight gain, but men, they'll actually have some mild breast development. It's involved in attention, which is why, again, stimulates our dopamine reuptake inhibitors or their dopamine agonists. So Ritalin, methylphenidate, all of those things. Motivation. So dopamine makes you want. It makes you want to do things. Dopamine is the chemical behind, sex and excitement and wanting to see a movie and really enjoying music and stuff like that. That kind of guttural wanting comes from dopamine. Involuntary movement. So dopamine, you guys, it's like WD-40. It doesn't cause movement, acetylcholine, but it makes movement easy and fluid. So low dopamine will lead to jerking movements, but high dopamine will actually cause fluid ballerina-like movements. And again, you see that in diminished dopamine in Parkinson's. Nausea. Just like serotonin, block dopamine and you'll block nausea, which is why profenazine and other antipsychotics are used to treat nausea. And energy, dopamine gives you get up and go. There's a reason people like methamphetamine. It's because it's a powerful, extreme dopamine kind of stimulant reuptake inhibitor. And it causes these big kind of like grandiose, excitable, I'm going to get stuff done. Of course, it doesn't do it in a logical format where you're actually getting things done the way that you want to. So if you increase dopamine, you improve mood, you improve focus and attention, you improve motivation, you increase energy, you can increase nausea, you improve sex drive, but you worsen psychosis and you can worsen sleep and induce insomnia. On the flip side, decrease dopamine and you can diminish mood, flatten affect, right? So you find this in people who take typical or atypical antipsychotics. If you've ever met someone on Haldol, haloperidol, you see them, they're just kind of like flat, right? You do improve psychosis, you definitely improve sleep, you improve nausea, you reduce energy, but you worsen sex drive. So what's interesting is serotonin and dopamine are kind of like wrestling partners. And I've used this because if one tags in, the other tends to tag out. So here's where we go with this fun, like, because the number one complaint that we tend to get about atypical or about depression, like antidepressants, like SSRIs and SNRIs, is loss of sex drive. And I don't know if any of you have been around a doctor who's like, oh, we'll just add a little Wellbutrin to that and you'll start having a sex drive again, which is very common. It's extremely common to supplement an SSRI with a little bit of Wellbutrin to return sex drive. And that's because if serotonin's up, dopamine tags out because you're satisfied, you're good, you're fine. If serotonin diminishes, dopamine will tag in and try and compensate for it. So what's interesting is if you have patients who have sexual, like diminished sex drive or anorgasmia related to their antidepressants, but they love their antidepressants, oftentimes what you can do is have them, I've actually had people where it's like, okay, so if you take Zoloft and you take it on a consistent basis, skip a dose like the night before, sexy fun time, right? You'll get a boost in sex drive temporarily for about a day. And as soon as you've finished, go ahead and take your medicine. And a lot of people actually they kind of have scheduled dates or planned times where they just they postpone their antidepressant. They get a little bit of that boost in dopamine because it doesn't happen at that consistent time. They have sex, they enjoy themselves, then they take their antidepressant. So this is why you see and you also see this with like constipation and diarrhea, right? Dopamine tends to lead to more constipation, serotonin tends to lead to more diarrhea. So you see this kind of flip in, flip out. But as you increase one, you tend to diminish the other because they work in partnership and they just kind of help each other out. So if dopamine increases, sometimes serotonin can go down. If serotonin increases, sometimes dopamine can go down. So that's something to pay attention to. And it's also why we will often try and supplement and see if we can't complete the picture. Norepinephrine. All right. Where is the vast majority of norepinephrine found in the body? Excellent guesses, you guys. So the vast majority of norepinephrine is actually found in the sympathetic nervous system. And this is very interesting because this is actually one of the functions why it mediates pain. How many of you have ever looked down in the shower and you've seen like a bruise or you see like, a cut on your shin or something and you go, where did that come from? Chances are at the time you were injured, your sympathetic nervous system was engaged. So you actually were not attending to or focused on the injury. You were focused more on a survival mechanism, so your body was able to ignore the pain or the injury. And that's why treatment like Cymbalta and Effexor, when we increase norepinephrine, we're actually helping the body to diminish its focus on pain. So norepinephrine, otherwise known as noradrenaline, is involved in fight or flight. So think fight or flight, concentration, focus, energy, heart rate, blood pressure, and glucose metabolism. So it gets its effect through, as someone said, adrenergic receptors. So we have your beta receptors are in your heart and lungs, and your alpha receptors are in your periphery. So I like to say, again, like beta blockers, that we used to treat blood pressure, those affect the heart and lungs. The alpha adrenaline blockers, clonidine, guanfacine, a lot of the ADHD meds, those tend to treat the periphery. And that tends to give you kind of that like post-massage, just systematic relaxation, which is why it's helpful for kids who are hyperactive. It's helpful for kids to get to sleep. It's helpful for pain treatment and some of these other things. So increase norepinephrine and you improve concentration and focus. You change sleep, but it's a paradoxical titration effect. So it's very interesting when we're messing with norepinephrine in the body, because as you begin increasing norepinephrine, it tends to make people a little sleepy at the beginning and then it flips. So if any of you have ever had a patient take Cymbalta or Effexor, it tends to make them very sleepy at the 20 milligram dose or when they're starting at low. And it tends to actually wake them up once they hit a certain dose. So I often encourage people, hey, if you just started Cymbalta or Effexor and anything in the SNRI category, including Strattera, which is just a norepinephrine reuptake inhibitor we use for ADHD, if you start those, start them at night, and as you dose increase, flip to the morning, because you'll find that they make you tired in the beginning and then they stop making you tired and they start waking you up. They reduce appetite and they improve pain. So one of the visuals I like to use as I'm discussing the 3 monoamines with patients and helping them decide what's the best antidepressant trial for me is I use this visual, and that is serotonin is your feel good, just I've got this. Dopamine is your ice cream, warm fuzzy, right? It's your super happy. So I say good mood, warm fuzzies, and norepinephrine is your get up and go. So I always ask people, what are you looking for? Are you looking for more, I've got this, I can do this? Are you looking for more warm fuzzies and the ability to feel excitement, and motivation again? Or are you looking for a little bit of get up and go, focus and energy? So Jeannie, so what I say is good mood, warm fuzzies, get up and go. And so that's the smiley face is serotonin, the ice cream is dopamine, and the cup of coffee is norepinephrine. So I'll talk to patients because oftentimes you'll hear from them. They'll say, actually, I'm really I'm fine. I need motivation. I need boost. I want that warm fuzzy. And we go, okay, well, Wellbutrin is a dopamine norepinephrine reuptake inhibitor. So that sounds great. Or if they're like, I'm far more interested in kind of the get up and go part of norepinephrine, and I have some pain and I'm having trouble focusing. So we can go straight on just Strattera, which is a norepinephrine reuptake inhibitor, or we can do a combination SNRI. So that helps us to understand when we ask patients, what are you looking for? These are the things we can treat. It helps them to understand. If they're bipolar, we use the house, right? And so with bipolarity, what we say is, I want to give you a nice floor. I don't want you in the basement. I want you on the first floor. And I want to give you a nice ceiling. I don't want you on floor 9 manic, right? So I always say, look, I'm going to build you a house. How you decorate it is totally up to you. But the goal of treating bipolar is to give you a manageable interior of a solid floor and a solid ceiling so you can handle that. And that we treat through the anticonvulsant mood stabilizers. But dopamine and norepinephrine are generally considered safe in reasonable amounts for people with bipolar. So Wellbutrin is considered a safe antidepressant. And then Strattera is considered a safe method of treating ADHD in people with bipolar. So I use the same thing. I say, look, if it's between me giving you stability of a solid floor and a solid ceiling, warm fuzzies, and get up and go, what are you looking for? Because we can calibrate meds for people with bipolar across the spectrum. Does anybody have any questions? And like I said, don't worry, you will have these images, you guys. So please, I actually draw them on a whiteboard. We have a lot of fun with it. So real quick, I'm going to talk about glutamate, GABA, and what we call voltage sensitive sodium channels, which are the anticonvulsants, right? So glutamate is the principal excitatory neurotransmitter. It's what we find in anxiety and agitation. So glutamate, so if you look at the GABA receptor here, which as you can see, it responds to barbiturates, GABA. Oh, sorry, will I share a list of each kind? Like, oh, of the actual antidepressant classes, like SSRIs, SNRIs, things like that, Janet? I am more than happy to provide that to you guys. I'll have to do it in a separate attachment. I'll prepare it for Jeff, but I can send you guys, if you would like kind of a general list of what medication fits into each class, I have those. I just need to find them in my computer for you. But I'm more than happy to provide that for you. Absolutely. So you guys, I'll get you that list. No problem. So glutamate is excitatory. So that's anxiety. GABA is inhibitory. So that's suppression, sedation, right? And so GABA is, again, what we find in benzodiazepines. They're GABA receptor agonists. They help, like, so 40% of your brain is dedicated to quieting and shutting things out, which, hallelujah, thank goodness, because otherwise we would pay attention to every sound and every feeling. So glutamate gets you up and going, focusing, attending. GABA brings you back down. If you drink alcohol for a very long time, you are constantly cluing into GABA, and your body no longer makes its own natural GABA butyric acid. And so what happens over time is when you drink or take barbiturates or benzodiazepines or anything that agonizes GABA for a long time, your body goes, why on earth am I bothering to make this high quality chemical when I'm getting it for $5 from the dollar store outside of myself? I'm just going to shut down production and wait for the chemical to come to me. And that's where addiction and habit formation comes. So GABA stands for GABA butyric acid. So, which is just the primary inhibitory neurotransmitter of your system. And it's very easily mimicked or synthesized, right? Again, you can see that this receptor receives barbiturates, it receives alcohol, it receives pain medications, a lot of benzodiazepines. So a lot of things sedate the system. And the more outside sedatives we use, the less likely our body is to bother with making its own. So alcohol-induced anxiety comes from prolonged use of a sedative, where when you go off the sedative, your body has a refractory period where it cannot inhibit itself. Your brain just can't shut down and calm down, which causes a horrific anxiety spike. So, and I'll go over these a little bit more detail in the next two slides. So, yeah, GABA supplements do exist. So, and they are highly sedating and they tend to be used for sleep. Yep. So you can absolutely, like, there's peaceful calm and stuff like that. So you can take GABA supplements. The problem is with the GABA supplements is similar to kind of the dopamine with crossing the blood-brain barrier. They're not as effective as the actual barbiturates and alcohol and benzodiazepines. It doesn't have the same long-term effects as alcohol. Nope, because it's very similar to providing your body the building blocks. If your body has no more storage, it's just going to dump it. So voltage sensitive sodium channels are anticonvulsants. So they mediate action potential. Yes, it can. So people who take GABA supplements, they're often combined with like L-theanine. Sorry, for those of you see Matt mentioned in the chat, could a GABA supplement help with horrific anxiety spike after going off benzos? Yes, it can. It's not going to be anywhere near as effective as the alcohol, but a lot of people especially take it at night to go to sleep. The other way we tend to treat anxiety related to alcohol withdrawal is with histamine blockers or those alpha adrenaline blockers like clonidine, guanfacine, or we treat with trazodone or hydroxyzine, which are histamine blockers. So some people just take Benadryl actually because histamine blockers work on a totally different channel and they just knock your system out. Anyone who's ever taken Benadryl knows that. But yes, GABA as a supplement with L-theanine and acetylcysteine, all of these different combinations that they sell on Amazon it's a very helpful over-the-counter treatment for anxiety. So when we're looking at anticonvulsants, what we're doing is we're slowing conduction. Anticonvulsants, gabapentin, Neurontin, right? They tend to be used for pain because we're slowing the conduction of pain. We're slowing the neurotransmission of pain. So if we slow the system down, like I said, think of it like speed limits on a freeway. If we slow the system down, it does not communicate as severely or as quickly. Same thing goes with mood stabilization. We use a lot of anticonvulsant mood stabilizers for mania because it slows mania down and therefore reduces its severity. So no, so that's a great question. So David Maxey asked, does long-term alcohol use at moderate rates, like no more than 1 to 2 standard drinks per day, have an effect on GABA production? No, it tends to be a tolerance building escalation that causes that systematic shutdown in the body. So when you look at the CDC guidelines, I don't know why they're still, kind of doing it this way, but for women, it tends to be, for biological women, it tends to be a 1 drink per day. For biological men, it tends to be 2 drinks per day. That tends to be kind of what they consider the normative drinking. And that has been demonstrated not to have a particularly significant effect. Just like people who take like an Ativan here or there, or, they may take a Valium or a Xanax before they go in an MRI machine. Episodic low use does not have an effect. It's when you start to build tolerance, and tolerance is literally the GABA receptor you see here shutting down sites to receive its own organic chemical and opening up more sites to receive the artificial chemical that we're using to treat it. And therefore it now needs more in order to be satisfied. So for the most part, the kind of standard drink format, and this is, addiction medicine is a totally different animal, but you tend to find people who have genetic predispositions for addiction tend to have sensitive receptors that actually do this process a lot faster. So I'm not saying somebody with a long line of alcoholism in their history might not actually struggle with that. But in this particular case, for the most part, the average population cannot build tolerance with that low and that quickly, if that makes sense. Does that answer your question, David? Okay, perfect. So when I'm using the analogy of glutamate and GABA, what I'll say is GABA, it minimizes the volume, glutamate maximizes the volume. So think of sensory overload, right? So when we turn the volume down, right, it's at a more manageable level. When we turn the volume up and it hurts, like you've ever been to a concert where you're like, I'm not enjoying this music anymore, it's just too much, that tends to be the excitatory. So high glutamate, anxiety, high GABA, sedation and calm. Same thing with the anticonvulsant mood stabilizers, think frequency, right? That fast agitated boom, 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 boom versus consistent pace. So mania, pain, agitation, anxiety, a lot of those things when we administer anticonvulsant mood stabilizers slow down and are more manageable. However, bear in mind, you can't selectively slow down the brain. Take an anticonvulsant mood stabilizer or an anticonvulsant like gabapentin, Lamictal, Depakote, all of those things. So what will happen is if you slow that down, you also start to have a little bit of gait instability. People struggling to walk as clearly, you can have some word finding difficulties. They can feel a little sluggish in their thinking. So is there any benefit to augmenting? Do you mean augmenting with GABA for dealing with overstimulation? I'm not, again, hypothetically, absolutely, like it makes perfect sense. However, I'm not sure the effect of the actual like augmentation, because augmentation with GABA tends to just be very sedating. So it might be a little overly sedating, but Gretchen, because it is a relatively safe, oh yeah, so GABA, L-theanine, and some of those supplements, like if you actually go on, like I think Autism Speaks has a list of supplements that they use with people with autism, and GABA is one of their recommended supplements. But if you go to, I think it's Autism Speaks has a list of, you can actually Google supplements for autism, and that's one of them. So mechanism of action. So we're going to take a little moment to kind of apply what we've learned, right? So here are some selective serotonin reuptake inhibitors: Prozac, Paxil, Celexa, Lexapro, right? So if we're looking at a selective serotonin reuptake inhibitor, remember domains, we're looking at improving mood, right? Improving anxiety, satisfaction, right? Kind of your general, there's a reason SSRIs are kind of considered the first line general defense. And then there's serotonin norepinephrine reuptake inhibitors, Cymbalta and Effexor. So as we think about SNRIs, now we're looking at diminishing pain, a little bit of increase in concentration and focus, right? Effexor is unique because as you increase Effexor past 225 milligrams, it actually starts to pull in a little bit of dopamine and make itself a tricyclic antidepressant, right? So you've got SSRIs, right, which are great for obsession, depression, anxiety. You've got SNRIs, which are great for obsession, depression, anxiety with a little bit more focus, attention, get up and go, and reduce pain. You have a dopamine norepinephrine reuptake inhibitor, Wellbutrin, very commonly known, which is great for get up and go, focus, excitement, happiness. It tends to be really good for treatment-resistant depression. Because people who have not responded well to serotonin or who don't metabolize serotonin well, they tend to actually do a lot better on Wellbutrin. And fun fact, you can take Wellbutrin because you see it's a dopamine norepinephrine reuptake inhibitor. You can add it to an SSRI and ta-da, you've made your own tricyclic antidepressant without the terrible dry mouth and other side effects that come from the tricyclic antidepressants. Anticonvulsant mood stabilizers, and glutamate voltage-gated sodium channel blockers. Fancy way of saying slow down, right? Slow down neurotransmission, stabilize mania and anxiety, and glutamate block, right? So if we're blocking glutamate, what are we doing? We're reducing anxiety. So a lot of the anticonvulsant mood stabilizers are phenomenal at reducing anxiety and mania. And they also, for people with bipolar, kind of pull them up out of the basement to the middle floor and they go, most people on an anticonvulsant mood stabilizer will be like, I feel even. Right. And by the way, they're not just for people with bipolar disorder. I have a lot of people with horrifyingly high anxiety that has just been resistant to a lot of things. And we can augment with one of these glutamate voltage gated sodium channel blocker, and they tend to do really well. So tricyclic antidepressants, tricyclic, 3 cycle, 3 antidepressants. These are the ones that Elavil, Pamelor, amitriptyline, nortriptyline, all of these reuptake all 3. So tricyclics were the answer to MAOIs, so monoamine oxidase inhibitors. You guys, monoamine oxidase inhibitors also they reuptake all 3, serotonin, dopamine, and norepinephrine, but they do it through a process that can cause extremely horrifying cardiac events if you don't watch what you eat and what you take. I mean, you can take an MAOI and combine it with Benadryl or some allergy medications and have a heart attack. So MAOIs have tended to fall out of favor because they're dangerous if people don't follow strict protocol. If they do follow strict protocol, they are phenomenal medications and probably the best antidepressants we have on the market. But if any food has tyramine in it, cheese, processed meats, things like that, it can kill you. So MAOIs tend to be dangerous, but they're effective if people can follow protocol. But a lot of our depressed patients aren't so great at following protocol. So MAOIs have kind of fallen out of favor. So TCAs took their place, but tricyclic antidepressants are highly what we call anticholinergic. So to quote another, like shits and shivers, to quote another nurse, can't piss, can't shit, can't cry. and can't spit, right? Can't piss, can't shit, can't cry, can't spit. So they're not actually, TCAs are the most discontinued of all of the antidepressants. So now we have a benzodiazepine GABA receptor agonist. So Valium, Xanax. So now you know GABA receptor agonists, they agonize, they enhance the effects of the GABA receptor. So now we know why benzos like Valium calm people down. They minimize that volume. Non-benzodiazepine GABA receptor agonists do the same thing, like Ambien. And many of our sleep meds are non-benzodiazepine GABA receptor agonists, which is why they're habit forming. Because if you overstimulate or consistently stimulate the GABA receptor on a regular basis, your body is incredibly efficient and it's not going to bother to make its own when it can get it for cheap. All right, I want to be sensitive to time and make sure that I cover some of the other components here, and I want to make sure I have a little bit of time for questions. So I'll just go through half-lives and metabolism. So the half-life of a drug is the estimate about how it takes about half of the time to leave your body. So 6 half-lives is considered terminal dose. So if something has a half-life of 12 hours, then you do 12 times 6 to find out when that medication is finally going to be gone from their body. Half-lives are important to pay attention to because if you look at medication, they have dramatically different half-lives. Prozac is fascinating because as you take it longer, it inhibits its own metabolism, so it stays in your system longer. So if you have somebody who's had a pretty bad effect on antidepressants before and is really afraid to take them, you probably don't want to choose something with an extremely long half-life because it's going to hang around for like a long time, right? So if they have a bad effect, it's going to be there until Friday. Whereas something like Paxil, which is actually pretty rapid fire in the antidepressant world, will leave their system sooner. Drugs like Cymbalta, right? People tend to actually get what they call brain zaps. They tend to go through with micro withdrawals if they don't take their Cymbalta as consistently. So longer the half-life, the easier it is to skip a dose, but the longer it stays in your system. The shorter half-life, don't miss your dose. You're going to feel it, but you can get off of it a lot quicker, if that makes sense. So it's important. I just wanted you guys to see that, like, look at Abilify, 75-hour half-life. It's like Abilify hangs around in your system for days. You take one dose and it just takes so long to get out of your system. So it's something to pay attention to. If people have had bad effects, take a look at the half-life and decide whether or not you want to put them on something that's going to hang around for a long time. So what do you guys think? Is it easier to get off a short half-life or a long half-life drug? So, it's so funny that you say that. So believe it or not, it's actually the longer the half-life, the easier it is to get off the drug, psychological and addictive factors aside, like if someone's addicted to something psychologically. But like Prozac self-titrates. So if you stop Prozac on Monday, it actually just systematically removes itself from your system as if you were taking half, a quarter, and all of that. Whereas if you just quit Paxil, it's gone. And Cymbalta, they're gone, and they're gone pretty quickly, which is like a punch to the system. So I tell my patients, they used to work on the coast, if you come to the beach and there's a cliff and there are stairs down to the water, I prefer you take the stairs. The cliff will get you there, but it will hurt more. So I want you to think short half-life, you need to go on a taper. Long half-life, you still want to taper, but it's easier to get off of. You can get off of it a little shorter because the drug itself actually tapers itself out of your system. Quick note about metabolism. The vast majority, like 99.9% of all of the psychotropics that we use, are renally or hepatically secreted. Some are solely hepatic, which is your liver, like Depakote. You guys, if somebody has liver impairment or they've been a former alcoholic and they're going to go on an anticonvulsant, they need a liver function test first because these things can be really hard on the liver and they can also not work if your liver is that damaged. Same thing with renal. Lithium. Lithium is 100% renally secreted. If you have diabetes or you have a history of kidney issues, lithium can beat the crud out of your kidneys. In fact, we actually see people who take an antibiotic. Sometimes just antibiotics can be really hard on the kidneys and it will accidentally like triple their lithium dosage. So it's important to be aware if your clients have diabetes or kidney impairment or hepatic impairment, that's something to have them say to their doctor, hey, just a quick reminder, I have liver or kidney issues. Does this drug affect that? So, genomic analysis. So Dave, he asked about what we call epigenetic testing. So there is a lot of evidence that certain people are not very good, like well responsive to serotonin. And so those can be helpful tests for medications to avoid. A lot of doctors are kind of 50-50 on whether or not they believe them. But for the most part, we have found genetic lineage. If your family tends to respond well to serotonergic agents, you will as well. If your family doesn't, you won't. And so epigenetic testing, that genomic analysis can be very helpful, but they tend to be around $400. So, and not covered by insurance. So it can be very cost prohibitive and kind of specific to socioeconomic status, but they can be very helpful. And then it looks like I have a hand up from someone. Sorry, Frank, did you have a question? Okay, well, we're almost about out of time. I wanted to go through some kind of fake cases for you guys, but that's okay because you now have the knowledge in order to kind of run through these things yourself. Does anybody have any additional questions for me or anything else you would like me to cover in the last few minutes that we have?
You mentioned that, can you hear me?
Yeah.
You mentioned that Lexapro was particularly bad with serotonin syndrome. Is that just from your experience, or is that documented somewhere?
So Lexapro is like a Cadillac of like, it's a really high quality and efficient antidepressant. Lexapro tends to be the most it has the highest sexual side effects and the highest incidence of anorgasmia. And Lexapro, when combined with other medications like gabapentin, even if you can look at National Institutes of Health studies on gabapentin combined with Lexapro, when combined with other drugs can cause serotonin syndrome at very small doses. So Lexapro tends to be sensitive. Now it's incredibly effective. It's one of the best SSRIs in terms of people reporting that they love it. And it also tends to have a higher risk for serotonin syndrome than others, and that's documented, if that helps.
Okay, yeah, thank you.
Absolutely. No, thanks everyone. I love this stuff and I'm more than happy to teach more on it. Like I talk about this all day, but I kind of wanted people to be aware because I think this really helps you to kind of explain side effects and talk about these things with your patients. Any other questions I can answer for people? Okay, so before you go, I want to make sure that you have your code. So this is the code that you need to use in your evaluation to get credit for the CEU. Christy has also posted it in the chat box, in the chat function. If you're like, oh my gosh, I didn't write down the code, feel free to send me an email or send info@opa.org an email. You can also email me directly if you have additional questions, you want me to cover something else. And for everyone, I will get that list of the various medications out to you guys. You'll get this PowerPoint and I'll get that additional list out to everyone. All right, thank you everyone. This was absolutely fabulous. I look forward to teaching more on it in the future, and I look forward to hearing from people if they have additional questions.
Thank you.